Invite my panelist Vijay. I think you should sit permanently here only. Come. Sunil is there. Sunil, I saw. Sunil is there. Last Pushpak, I don't know whether he has turned up or not. Pushpak has not come. So we have a selected panelist. So we'll start with the. This is not moving. You're given the control here. Okay, fine. So today's meeting, basically the background is to see that we know that the venous access is very important. We'll discuss about chemo ports and PICC line and which patients are best suited for which. I think we'll discuss, and we'll try to go with the global guidelines. Also our Indian practices and how we are trying to resolve the barriers, which I think is becoming very important. So just Vijay, I just want to ask one question. How much usage you are now giving importance to PICC line as compared to port now? We'll not go with this question. In your practice, out of 10 patients, those who require VAD, how many are going for PICC and how many are going for port? 8 port and 2 PICC line. Sunil?
50-50.
50-50. Okay, fine. So I normally go for PICC line more, slightly more, because the dependence on the surgeons is less. I myself do not know, because my earlier senior medical oncologists, some of them had learned putting a chemo port also, and they used to put it. But yes, I go for PICC line more because sometimes you don't have time to make them convinced for going to the OT next day and going for the port. So just one thing is that we look into the algorithm in India. I think there are things which are changing in our practice. Our daycares are now making more usage of the PICC line. So anything else, you feel the awareness is your next few years, in the next 5 years, you think the PICC line usage will increase or it is going to decrease?
So at least in my practice, I'm trying to increase it. That one of the reasons why this was queued is because in my new place where I'm working, there are not dedicated sisters to handle the PICC line, teach them the way in my alma mater, TMH, they used to happen. So we actually have sent 3 sisters for dedicated training for handling the lines, not only for the chemo patients but also for the ICU patients, because I think we need a dedicated team of sisters to take care of these lines. If they are blocked, what needs to be done? If they are infected, what needs to be done? Because I see that our reflex actions are not very guideline oriented. If the patient is spiking, you would say, okay, remove it out. So that is like the reflex action which we have.
Right.
You have seen that in TMH many times the sisters used to put their foot down. We don't think that is. Even the infectious people would say we don't think that is. Continue with this conservative, and many times we have actually preserved and got away with the line. So that is the reason I think we need to have a dedicated team which can handle the PICC lines. Not only for putting it, but also for counseling the relatives how to do the dressing, or else they come up with very bad infection at the insertion sites.
I think even in Tata, if you see in the last 15 years, the things have all dramatically changed. There's a whole new department looking into it, and I think you see the usage of, as compared to port, PICC lines have picked up a pace very nicely. Usage of port has gone down a lot, and PICC line, the advantage is that yourself right now you are yourself trained for putting, or you're just making the staff only.
So I know how to put a PICC line, but I need 2-3 sisters to be there to tell them about dressing and all those things.
Right. I remember around 15 years back I learned it myself. So, but I think the things have changed. What you said is right. The responsibility, basically, once you have a department, it becomes very easy to monitor it, because there are not one issue which happens with PICC line apart from the dressing and the regular dressing. Apart from the other issues related to it, sisters are able to manage very nicely, especially the exit site infection. They are very well trained. Most of the times it doesn't come to us, it gets solved by the staff's action. Sunil, anything else you feel that your usage has increased or it has gone down?
Definitely, PICC usage has increased over the time, and that regarding the awareness about PICC, whenever it is at the centers, which are say tertiary centers, the nurses as well as the doctors over there are not well trained. So I try to try to implement whatever guidelines we have done at TMH, and they are focused on training the dressing to the patient, training the dressing to nurses who are taking care of this patient. So yes, I am trying to use PICC more.
So I think the issue never happens when you are working in a big hospital where the X-rays are already available. It acts like very easy, but it happens a lot when you are running a daycare where you need to put a PICC line. It becomes a very big difficult thing because every second moment the line goes to the neck, and then you have to shift the patient back to some X-ray, then bring it back, and nobody keeps an X-ray machine in their own daycare center. So daycares, somewhere down the line, I feel maybe in the near future, I think there will be only a PICC line daycare specially meant where you can send the patient, get the PICC line done, and you can bring them back to your daycare. This thing might happen.
Putting it under fluoroscopic guidance is much easier.
Much easier
than we think. Blindly, sometimes, many times it actually ends up in places which you cannot even.
So half the time you will go on blaming the patient, या तूने गर्दन सीधे नहीं रखा है और टेढ़ा रखा है, another thing. So that becomes like a big issue. So I feel that somewhere in the future we might have, but what you said is fluoroscopy is something which is very much important, and only when we have a VIP patient we do it, otherwise half the things is only for that thing. One more, Vijay, I think, has anyone tried deep vein PICC line? Deep vein. Anyone tried the deep vein PICC line? Most of us are putting all superficial vein, right? Has anyone tried a deep vein? I think this culture might change. I think BARD might be, BD might, I won't say BARD, BD will say that there is a system called deep vein sonography guided. They used to put it like, it's like, works like a tunneled one. Only disadvantage is that you require a sonography machine and you need to go little bit deep inside the muscle. The disadvantage is that after putting a line, a patient will get a swelling for 1 or 2 days. Gradually it will settle down, but the biggest advantage is that even in a patient who has been frequently given so many chemos, you will find the vein. And the infection rate is slightly less.
And even the hand movement
is much better. You can go basically above it. Right now our staffs are all trying to put it above so that every patient can go around in a bike. That's a different thing. How commonly you are changing the dressing? अभी तो तुम प्राइवेट में आ गया है. Now it is very.
So no, I got one sister trained for that. So
every week you are doing changing the dressing.
I actually instruct them to do that. If they not, I'll tell you where my PICCs are put. My PICCs at present, if it's like breast, they are port itself.
Yes.
So PICCs are specifically when I go for like these long infusions of 5 few, then so they as such come every 2 weeks or 3 weeks. But 1 weekly dressing I advise them to.
Okay. Sunil? Weekly. So I changed it to 2 weekly. I'm just telling you, for the last 7 years I am practicing 2 weekly. The main reason was that Folfox was a Folferi, and right now it has worked very well. So I started using PICC line in 2011, and 2015-16 onwards I have made it 2 weekly. And 2 weekly does well in spite of so much guidelines talking about weekly, but it's very cumbersome for the patient to come. But the good thing is, I think dressing material has also improved. Infection rates are not so bad. We give them socks to wear it so that the chances of getting infection is less. I think we will not go too much. We know where to put it. Irritant, vesicant, we all discuss about it. And these are the things which are important. So I think this is a venous access global guideline. MAGIC, the Michigan guide for intravenous catheter, up to 5 days, critically ill patient. They talk about CVCs. For cancer patients receiving chemotherapy, PICC lines and tunneled and port. Have you tried to make your ICU people think about putting more PICC line in their ICUs? This is going out from the cancer patient.
So in fact, in Car Hinduja, the whole idea of starting the unit came because when I put my foot down, I need a unit, the ICU people are more than happy that we'll make a combined unit so that they also, their PICC lines also are handled by the same unit. In fact, then the whole hospital agreed that this 4-5 nurses which will be getting trained will be handling the PICC lines of the whole hospital.
So why I'm asking, because I started this whole concept to the ICU specialists around 6 to 7 years back. Their funda was very clear. Center line is mainly to look for the central venous access. I said the pressure monitoring, who does it nowadays? No one does a central venous pressure monitoring. And PICLINE is good thing is that the care is become more better because we have more dedicated staff. One of the best way to push your hospital to go for is to involve the IC fellows. It becomes easy because they look at the volumes and do it. And PICLINEs are very helpful for all this patient. Recently we had one patient on antifungal amphotericin B. We gave it one patient on osteomyelitis where TB, tuberculosis also we had long-term MDR TB where they require to be given. PICLINE becomes like a very big usage. So this is just an algorithm to give a define where the ports and PICs are used. But remember one thing, PICs are something which can go for a short duration also or for a long duration. So this is what we are looking at parameters. We talk about infusion, intensity of dose, expected duration of treatment, vascular integrity, patient appropriate. Anything else apart from that, Sunil?
Finances are missing.
Yeah,
Port
but
versus phase.
so port is much more costly, right, Priya? Don't. No, it all depends upon the level. That will go. Don't you think right now medical oncologists are less sending you for any port?
कोई फर्क पड़ रहा वो सर्जरी के लिए देखा और the fact remains that we also had a study published a paper on cost benefit ratio. So PICC definitely the insertion cost is less, but when you come to maintenance cost, it actually becomes more expensive in PICC because both you flush once in 6 weeks, while you end up pressing every week or so in PICC. So other than patients where you require a long duration therapy, I don't know whether the cost will make a difference or not.
So I think one of the reasons why we have become slightly less dependent on PICLINE because the staff, you need not wait for the OT timings and sending the patient. You can just do it on the same day the PICLINE. Like in the morning, I saw 2 patients. Both the patient I told put a PICLINE and start the things. So you do not wait for the port. But yes, you feel the infection rates are more with the PICLINE as compared to port?
No.
Okay. Sunil? Same. I felt slightly less. It depends upon also, but yes, what she said is right. Port is something which we are more thinking is a breast cancer patient, which we put it like that. So this infusional monoclonal antibody immunotherapy, anyone putting the PICLINE? Chemo plus immunotherapy? In lung cancer, anyway, this meeting is for more lung cancer. Do you think putting a PICLINE in lung cancer patient, you are putting less number or?
No. So if a patient is planned for like a immunotherapy protocols, I actually counsel them to put it. Because what happens is if they start responding, you will give 4 cycles and then the maintenance is
right.
And after some time you see that there are no veins which are left. And the second thing is what I found now, especially if they are females, now they're much worried about those markings which they are seeing.
Yeah.
More than the febrile neutropenia, the alopecia and the marking makes them more.
Yes.
So I can't do much for the alopecia, but at least you put the lines or the put that markings disappear.
Right, that's the truth. Yeah. So these are the vesicants, irritants where we look into it and where we try to put the things. I think that is what everyone talks about. Wherever you have using a vesicant irritants, try to avoid any vascular complication. Like I think 5-FU is a big culprit. We had been using 5-FU from not from infusion. I had used in the hand like crazy. I started when we were giving for 5 hours, 6 hours. Then it became suddenly 48 hours. So it became so difficult. And there was a regimen previously 5-FU Lucaven, which was not infusion, bolus only. So that was the best time not to worry about the lines. But I think after the infusion has come, it became very difficult to continue giving through the peripheral line. But extravasation thrombophlebitis is very important. Now just one more thing. Do you use the PICLINE for this phlebotomy, blood sampling?
I use port and PICLINE both I use for the patients. Blood samples will be
going with it. What is the disadvantage, Sunil? You feel any disadvantage with the PICLINE regarding the blood sampling?
In hospital patient, I do use PICLINE. But whenever it's an outpatient visit,
it becomes
right
right.
Because maybe the sampling people are not aware of
Agreed. I feel that is very important. Is that what you said is very right. I had the incidents where where if the staff is not trained to pick up the proper blood sampling, it becomes very difficult. The sample gets, you will not get a correct value of CBC also.
What we do is now we call them in the daycare, and at the same time, that trained staff only. Will
Yeah. So I think the training is also required for blood sampling. It's not only for the things also. What about blood products? We all of us give it to the thing. One more important thing is looking at the TPN. Will you use a PICC line for TPN?
I've used it.
Okay.
I've used it.
And what about
I am also using.
port for TPN?
Till now, whichever ports I've used, none of them have reached the stage regarding the TPN. So no, most of the time my TPN uses comes in DCF when they developed a lot of gastroenteritis and the albumin is falling, and I'm worried that they may respond and then the surgeon says his general condition is not good for taking him for surgery. That's the time I actually give not TPN but at least PPN to the patient so that the albumin levels come up. So that time I do it with the PICC line only.
Priya, somewhere I feel that TPN is not suitable for the port. I had seen, honestly, this is the one which I felt that TPN and port do not go hand in hand. PICC line is something which, like ovarian patient, obstructive patient, where you have to keep them on a TPN. I normally prefer putting the PICC line. Infection rate, I found it to be very high with the port. One more question, contrast.
Both CT contrast and PET contrast, I say no because I'm not sure about which nurse is going to handle it there. So I say no. In fact, I landed up in problem because recently someone tried to use my port for giving a PET contrast and there was necrosis over the. So it's absolutely no. Unless they have trained sisters, I say no. No, don't touch my lines for this.
So honestly speaking, ports are not meant for the contrast.
So there's a new port which is there.
That is different. There's a new PICC line also. That's also a different thing. There's a new PICC line, there's a new port. I had a tough time with the new PICC line also. I'll tell you, it got already, you require it because what happens is that when we were resident, we know how to push the contrast fast and run away from the CT scan department. If everyone has worked in the CT scan department, they will understand that you have to literally push it fast and run. So the problem happens is port, I felt like is not meant for the fast infusion. What you said is very right. And PICC lines are also not meant for the contrasting. I think this is something one. But yes, TPN I felt somewhere down the line, PICC lines have outperformed slightly better than the port in that area. But what Vijay said is, and Vijay Sunil said is very right. Blood sampling, I felt you do it only in a center which is trained for it. Otherwise, it becomes very difficult. Otherwise, your report will be wrong or something will be, suddenly the platelet will go down or it will come up, hemoglobin will shoot somewhere head and down. So these are the guidelines for basically we naturally go for PICC lines for those patients. This is also one more important thing. Sunil, average indwelling time of PICC line in your practice?
For breast cancer patients, it is up to
PICC line. PICC line. So this is purely PICC line, no port.
6 months.
6 months. Average. Good.
Most of my patients are head and neck cancers, so it is averagely for the.
Your practice will change now and coming hard. That is different thing.
So it's on average for 2 to 3 months only.
So head and neck, I think you have no other choice to put it over there unless you're giving it 2 drug therapy. So average indwelling time, I think it varies from center to center. I feel if you have a trained staff in a good center, it works very well. All these leaks happening, they are having punctures happening, how to repair it, and using different modalities, I think they do very well. It all depends upon the center where you're working. My experience is around 6 to 9 months maximum. In your case, highest 6 months.
In Tata, when I was in the other departments, it is up to 1.5 years long.
So mine, one of the patient was basically online for 2.5 years because of colon. No colon, you can go on trying whatever you want. That is what is important. So I think it varies from, but it all depends upon a good staff. And dwelling time varies from 7 days to 34 months. But mainly meant for patient where you are using it for 6 to 12 months, and it can stay in arm as long as 12 months. So this is the international authorities endorsed use. There are that it varies from 100 days to even up to more than 300 days. So it is not something which is uncommon. So it is just a matter. What matters is that you require a good staff to manage it. Median time is 184 days, around 3.8 years. In India, I think several centers have used PICC for 12 to 18 months. I think in the last 5 years, I feel most of the tertiary institutes have started giving a lot of importance to PICC and usage has also improved because we have a lot of trained staff. I think they are the best, I will say, for infectious disease control also. So, do we ever estimate what the patient will go through the expected? This is something very important because if you see this chart here, this is a hypothetical case of a CA lung only. You can see that 72 pricks in a year. It matters a lot. You know, just day before yesterday, one patient basically, she was a case of Ewing sarcoma. My girl came and she mentioned to me, 16-year-old, she mentioned me that she was pricked for at least 300 times in a year for blood collection, chemo, lot of. I think this is, if you start charting every day, you will come to know that pricking is very common. Our tendency to send the blood sample one day prior, it becomes like a big issue. But if you are working in a big center where you can get a report in 1 hour, it matters a lot. So pricking also decreases when you are putting them on some kind of, basically if you're putting them on PICC line or thing. So venous access status needs to be checked before starting each chemotherapy. This is one more case of CA ovary where multiple chemotherapies are given and later on they ultimately become, they go into subacute obstruction and ultimately will require some kind of TPN. This is a paper from Kidwai looking at the outcomes, cost comparison, patient satisfaction. You can see the median catheter indwelling time is for PICC line is 59 days, chemoport 137 days. One more thing, Vijay, do you basically for a port, how frequently you ask for flushing or you don't require flushing?
No. 6 weekly.
6 weekly.
That is appropriate.
You need to always mention them to take heparin or leave it?
I leave that to the unit.
Okay, I had one incident where one patient basically was very particular that heparin has got a bovine and porcine. Nowadays there is no bovine heparin, you have only porcine heparin, right? And she refused to take a porcine heparin because it was mixing with her religion. So a lot of discussion happened what to do, what drug to use for.
Why did you inform the patient about
I never informed. She picked up the sample. I never informed the patient. I came to know through her. Through her, I came to know that heparin is only porcine. Nowadays, bovine has already discontinued. That's why I took the question. So what to do? It happened. But basically, there was a paper, small paper, that you need not always use a require heparin. You can think about using a normal heparin. Normal saline also is sufficient. This is just to tell that. I think BD also says, they always sell, they give you heparin, no?
So it is not recommended 100% that for PICC line because it's such a valve catheter.
Yeah.
It is not recommended.
So my question to that patient was, what is happening in the Gulf countries, whether no one is reading that leaflet or not? Anyway, this is the cost comparison. These are the complications related with the CVC, PICC line and chemoport. Chemoport had less complication. Indwelling time was much more, and this is what happens is that if your institution policy permits trained nurses, I think you can reduce the cost by more than 61%, insertion rate by 91% and complication rate by 3.8%. Some of our sisters are more better trained than us in pricking and taking the thing in the first go. So this is the USG guided insertion. Nowadays you are using USG guided or just go with without that guidance?
We do it fluoroscopy guided.
Fluoroscopy guided. Which cost might go up, no?
Yeah, cost goes up, but then the issue is that
Success rate is slightly
success rate is
better.
much high.
Yeah, I think we are still using we are not using a sonography guided. There's a vein detector is there, no? That helped us out there.
What BARD needs to understand is the BARD needs to, where I felt where the
It has become BD now, no?
Yeah.
You have to speak BD.
Okay, so what BD needs to understand is that I think the time has come then for them to see the thing, because Tejinder, when we all got trained, we used to be very small number of residents and lines used to be managed by us. We used to put lines at that window. Now with most of the institutes getting this PICC units and this, the disadvantage of that is that the exposure of the trainees to there's complications of putting the handling of this has gone down. I think they need to step up at conducting seminars, not seminars, but practice sessions on how to put, how do you assess, because many of the times ultrasound guided or fluoro guided, we commonly see in videos, we commonly see in and then suddenly we have to think about thinking. So I think one of the things which you need to understand that if you want the use to go up, you need to have some practical workshops where you teach people how to put those on dummy, what do you say, that's...
Yeah, they have a dummy with them all the
They
time.
have a dummy, but they're not doing
In
those
spite of a dummy, one of my staff had put a guide wire inside and went into the heart. We had a tough time to remove it.
So we have a medical team also, sir, who come to the center and they can give the training to the
So
nurses and-
that they come to the center when we call. I think you have to proactively go and say like this training going on in Tata, Hinduja, AIMS.
And they have put all those things.
Yeah.
See, they made me read this
Yeah.
5 centers with so many training sessions.
So
So,
this training session must be of the nurse. I'm not aware of our residents undergoing those training sessions.
yeah, resident we have to teach them to sit with the staff. So my resident initially were not knowing how to put a needle in the port also. So I think right now I don't know how many residents they know how to put port needle also till they start
See,
working.
and the question is not, the question would be how many know that there is a
Port is
special
there.
kind of needle is required. That is one of the first questions you need to ask.
That's very important, I think. Yeah, I think. One day I was telling my resident to search where is the port. She was not able to find it also. It becomes very difficult. So these are the, looking at the center of excellence, they do have centers and they are trying to look into building ecosystem across centers. And I think this is what I stressed out, weekly dressing and flushing. Like I said, I started going for 2 weekly. And one more thing, complication, compliance, I think these are all, you require a good trained sister to guide the patient also, I think. Because the leak happening and infection happening, they need to be addressed. But any premature removal PICC line happening with complication, Sunil? Not much?
Not very frequent, 5 to 10%.
5 to 10%. Vijay, anything?
So normally this happens when only when the patient is spiking a lot, and those kind like you have you have already escalated your antibiotics, you're not getting anything. That is the time you would pull the PICC line off.
Luckily in solid tumor it never happens so much. It's all
very
leukemia.
leukemia.
Yeah. हम लोग के पास वो इतना सोचने का जरूरत नहीं होता. Leukemia it becomes. And looking at this care bundle, no, they have this sutureless stabilization device, pre-filled saline flush. You think it is advantage, Sunil? So they have brought this stack lock, no, stabilization device.
So I was about to talk about stat loss.
How cost पड़ता है उससे?
3 or 4 patients of mine have developed severe allergy to it.
Right.
So I was about to discuss it. I don't know where we place it. The patient will develop some lesions over there,
Hmm.
and it happened in the same patient.
Same patient.
So I was about to say.
So you have to change the patient.
Yeah.
So anyway, Vijay, I think we'll finish up with the last slide. Your experience is stack lock.
About 2 patients in which I have put up till now. Thankfully, I have not encountered that.
So I do not know where this pre-filled saline flush will work, but I think this is also they try to provide. So this is what is recommendation for central venous access devices. They need to look into chemo agents which are having a pH less than 5 and more than 9. TP and blood products, I think we are very much using. We need to make a habit of formally checking venous status for every patient who will be starting on chemotherapy. And every center must provide options of port and PICC line. Contrary to common misconception, and PICC line has been successfully used for short, intermittent as well as long-term therapy. I think the usage in ICU is going to go on increasing a lot, and benefits in both continuous and the intermittent chemotherapy. Thank you everyone.